Good morning, this is Miss Terry, and we're going to discuss chapters 25, 26, and 27 for your Unit 5. Let me make sure I have the right chapters. 25, 26, and 27, drug therapy for seizures, Alzheimer's, Parkinson's, and psychiatric problems. Okay, we're going to start on page 401, chapter 25. You know that a seizure results from an excessive or disordered electrical activity in the brain. So it's a electrical dysfunctioning that's going on in the brain. A person with a repeated seizures is considered a person with a seizure disorder, and that is sometimes called epilepsy. So a seizure disorder is often called, the term you hear is epilepsy. About 10% of Americans experience a seizure at some time during their lives. About 60% of these people never experience a second seizure. So, and a lot of times you hear teenagers have a seizure, certainly children who get a high fever have a seizure. But certainly a large part of our population who have had head trauma, particularly high blood pressure, various situations like that, can have seizures and then have a seizure disorder. Looking at the key terms, we talk about an aura, and those are strange sensations a person may experience, a tingling, a smell, they'll see lights sometimes, and that's considered that they have an aura. They're having an aura before a seizure. And we talked about epilepsy. Then we have first-line drug for seizures, and what a generalized seizure is. That a generalized involves the entire brain, and it's caused by electrical discharges on both sides of the brain. Partial seizure. Post-ictal, that's the phase after the seizure in which the patient sometimes is, post-ictal is, they're not real responsive. They're kind of still real sleepy. That's the post-ictal phase. You have second-line drugs used for seizures, and status epilepticus, which is a prolonged seizure that usually lasts more than 30 minutes. It's a continuous state of seizure activity, and it's very serious. So moving on to page 402, a person who has seizures is more likely to have a seizure during times of increased emotional or physical stress. So that's a time to really watch, especially if they've had a prior seizure. Of course, they're liable to have another one. We talked about aura and the post-ictal phase. You need to know those. Common causes of seizures: brain injury, degenerative disorders, developmental disorders, disorders affecting blood vessels such as a stroke. Many of your stroke patients will have a seizure. Infections, meningitis, stuff like that. Metabolic abnormalities. So if they're having kidney failure, nutritional failure, liver failure, or tumors. Risk factors, box 25-1, you need to read. Common cause, seizure causing drugs. So there are drugs that can cause seizures: antidepressants, cocaine, that sort of thing. Risk factors are what can worsen a seizure. We did talk about stress, lack of sleep, pregnancy, etc. Generalized seizures affect most or all of the brain. There are 6 types of generalized seizures: tonic-clonic, and those usually are, we call those grand mal. They usually last 2 to 5 minutes. Very stiffening or rigidity of the arm and leg muscles. They lose consciousness. They have spasms. They have a epileptic cry, which is a forced exhalation. So you have tonic-clonic. Those are the big seizures, grand mal. Clonic seizures, those are characterized by muscle contraction and relaxation. And then you have clonic seizures. Those are sudden increase in muscle tone, loss of consciousness, automatic signs. So you can have either a tonic, a clonic, or a tonic-clonic. Then you have absent seizures. Those occur frequently in people, and we call those petit mal seizures. And usually the patient, it looks like they're daydreaming, or they might just sort of drop off. Or I've even seen patients that do it, and you think they're having almost some narcolepsy. They just sort of leave you for a second there, and they're having petit mal seizures. And then myoclonic seizures involve brief jerking or stiffening of the extremities that last only a few seconds. And atonic seizure, typically there's sudden loss of muscle tone for a few seconds, followed by postictal. So you see there's about 6 different types. Generally what we label them are tonic-clonic or petit mal. Those are the two big kind of categories. And then you have partial seizures. Those are focal or localized seizures. And there are 2 major types of those: a simple partial and a complex partial. You need to read about that. And then status epilepticus, that's what we talked about, that's the seizure that lasts 30 minutes or longer and very severe. And you very well could be seeing those in the hospital. And that's an emergency in which hopefully you have an IV already established, get oxygen, open their airway. Very different from the way when I was nursing that we treat seizures now versus the way we treated them back then. But now you just want to get the patient, if they're already in bed, you want to try to get them in a position that you can take care of them, loosen if they have a gown or anything obstructing around their airway, remove, of course, any sharp objects, and you want to turn the person over to their side. And if they're in the bed, we still, pad the bed rails, that sort of thing. But you need to read how to take care of a patient who's having a seizure. And generally now we get them oxygen if we can, get their IV, their airway open, watch for their IV, and wait for the doctor to order, and he'll usually order IV Valium or something like that. Protect them from any kind of injury if you can. Okay, so, and the use of padded rails, as you see in page 405, is controversial. But you certainly want to protect them. You will do whatever your hospital standards are. I believe in if they're really having a lot of jerking or whatever, you want to try to protect them with pillow or a blanket if they're hitting the rails, certainly something like that. But that is controversial nowadays. Types of anti-seizure drugs, that's a major part of controlling seizures, is to give them the medications. Before you give any medications, though, you always want to get a complete list of drugs, because as we said before, certainly a lot of drugs can cause seizures. So you want to know what they're taking over the counter and herbal. Drugs, especially like Dilantin, you need to know can interact with a lot of other drugs. So you want to make sure you get a list of all their medicines. But you need to know that Dilantin can certainly interact with a lot of drugs. It can interact with Coumadin and cause increased bleeding. You want to check their baseline vital signs, level of consciousness, their gait, know about them, and make sure, like I said, the bed is safe. Low bed, side rails raised, call light in reach, that sort of thing. After you give anti-seizure medications, you want to check their level of consciousness, because they can be have sedating effects. And you check their vital signs and make sure they're safe because of the dizziness and sedation. Then you're going to monitor for seizure activity. And then if you're sending them home on seizure medicine, you want to instruct them to take the drugs completely as prescribed and to not suddenly stop taking these medicines. You have to titrate most of anti-seizure medicines off, and patients can get off of them. And take a missed dose as soon as possible, and don't skip a dose, and don't take a double dose for sure. But teach them about all of those sort of things, to call their physician if there's been any change in any of their other meds. You need to tell them to definitely avoid alcohol because of the dizziness and issues with safety. Wear a med alert bracelet. Usually if patients are on some sort of seizure medicines, especially for a short period of time, they're not supposed to drive. And so you need to read about general teaching related to seizures. So you have first-line drugs, and those are listed on page 407. Carbamax, Tegretol is a very common one. Dilantin, as we mentioned earlier, very, very common. And Depakote is the third in the first-line drug medicines. We want their seizures to be controlled and prevented, and the abnormal electrical impulses to decrease. We talked about side effects, ataxia, the clumsiness, I can't say that word, dizziness, lightheadedness, drowsiness, and then Dilantin can cause GI symptoms, and double vision. It can cause double vision, nystagmus, hypotension, gingival hyperplasia. We talked about that, gum overgrowth, rashes, etc. Side effects for which the patient should call the doctor can be any rashes, easy bruising, petechiae, nosebleed, unusual bleeding, that sort of thing, and they certainly do need to call. Now, adverse effects, neutropenia, you would suspect decrease in white blood cells, aplastic anemia, again, too few red blood cells. So they're very harmful for our immune system. So decrease white blood cells, red blood cells. Thrombocytopenia, low platelet count, therefore the bleeding. And then that Dilantin can lead to Stevens-Johnson syndrome. We talked about that in Chapter 1. It's a serious, life-threatening, systemic, body-wide reaction that involves a rash and burn-like sores on the body. This is usually a very serious reaction to the drug. So Stevens-Johnson syndrome, very, very serious. Also, you need to know that valproic acid, which is Depakote, the third one here on the list on page 407, is very harmful to the liver and the pancreas. So patients can get pancreatitis, liver failure, that sort of thing. And I was thinking this morning how many of the drugs that we read about, teach about, are liver, very serious to the liver and kidneys. And now we're seeing the pancreas get involved with valproic acid. So one thing for nurses to remember is never take any of these drugs lightly. Teach our patients how to take them on schedule, take them as the doctor orders. Don't take a lot of other meds that your physician does not know about. Very, 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 very serious issues with liver, kidney, pancreas disorders, that sort of thing. So it's very alarming to realize how many of these meds can hurt our vital organs. Okay. Then on page 408, there's a picture there of gingival enlargement. We've talked about that. That's particularly important for adolescents. So many adolescents who have to take anti-seizure meds have then this problem with their gums. So those three drugs were the first line for partial and generalized seizures. So for partial and generalized seizures, Tegretol, Dilantin, and Depakote are the three main ones. Then we have first-line drugs for absent seizures. And remember, the absent seizures were the Petimol seizures. Zeronotine and Depakote are the two main ones. Again, they can cause nausea, vomiting, indigestion, decreased appetite, weight loss, neutropenia, some of the same issues. Then we have the second-line alternative drug for seizures, and they are Klonopin, Neurontin, Lamictal, very common one, Lamictal, Luminol, which is phenobarbital, Lyrica, Mycilin. These are some of the second-line drugs for seizures. And they are alternative drugs for treatment. They block or slow the spread of the abnormal impulses. The disadvantage of the phenobarbital, of course, that's in this list of second-line drugs, is dependency that we have talked about before, and we'll talk about again. That you need to read how second-line drugs work and what their side effects are. But we want their seizures to be controlled. Electrical impulses, of course, again, decreased, and resistance of CNS to abnormal stimuli is increased. The side effects are listed there. They're different for each category, but most of them all include drowsiness, dizziness, that's some GI stuff. So that's pretty much it on seizures, first line, second line drugs, no side effects. Again, I usually do not ask you dosages, but you need to understand what the types of seizures are, where they occur in the body, and what we usually do to treat them. Know the aura and postictal phase, that sort of thing. Okay, moving on, drug therapy for Alzheimer's and Parkinson's. Alzheimer's is a progressive, incurable condition. Remember, you know that it destroys the brain cells, gradually causing a loss of intellectual abilities, such as memory, and extreme changes in personality and behavior. Very, very sad, long-term disease that is incurable. And then Parkinson's is a progressive disorder of the nervous system marked by muscle tremors, muscle rigidity, decreased mobility, stooped posture, slow voluntary movements, and a mask-like facial expression. So we always talk about Parkinson's when we talk about a shuffling gait, and you'll see your patients with Parkinson's kind of drag their feet with what we call a shuffling gait. So they're both progressive neurological disorders that are more common as we age. Alzheimer's is the most common form of dementia that there is, that we know of. Parkinson's is neurodegenerative disease with slow and progressive degeneration of the nervous system. Both involve interrupted transmission of nerve impulses. Transmission of these impulses is normally helped by the presence of neurotransmitters. Remember that? For example, dopamine and acetylcholine. These are chemicals that transmit messages from one nerve cell neuron to another. And so patients need neurotransmitters. We need neurotransmitters to transmit these impulses from one nerve cell to another, and with this disease, those are interrupted. We talked about what Alzheimer's is, and it does affect hundreds of thousands of people in the world. The two main pathological changes in Alzheimer's is the presence of large protein beta amyloid, which clumps together in the brain and causes plaques. And normally, if a patient is suspected nowadays of having Alzheimer's, they'll do a CAT scan to see if these protein beta amyloids are in the brain, and they can actually see them on a CAT scan and know, then they can pretty much diagnose Alzheimer's if those are present. Second, other proteins twist and form tangles within the neurons. As a result, these neurons die, and that's what helps us with our memory capabilities. Connections between the nerve cells are then disrupted. There's no single cause established for Alzheimer's. Instead, it's a composition of factors. The greatest is a genetic risk factor. I'll let you read about that. And you see, it's interesting on figure 26.1, what part of the brain is affected by Alzheimer's. And the front of our brain is memory, and behind that is language. So important. Symptoms, early, middle, and late symptoms, you can read about those. There's no cure. And drugs, there are types of drugs, and acetylcholinesterase inhibitors is one. That's a mouthful for you all to try to remember. And memantine. And those are listed in the chart on page 419. But memantine, which is Namenda, blocks amino acid glutamate, and it can be effective in helping to modify dementia temporarily. So the common one that we see most often given is Aricept, Donzapril. That's the one I've seen most often given, Aricept. Then we have Rimonel, Namenda, and Exelon. Those are all listed. And intended responses, you can read that. Adverse responses, most of them cause nausea, vomiting, dizziness, headache, fatigue. And with the memantine or Namenda, they can get shortness of breath, hallucinations, that sort of thing. Symptoms of overdose, be sure you know this, includes upset stomach, vomiting, drooling. So if your patient, you start noticing is drooling a lot, or if your family member and is on any of these medicines, that's a sign that they may be in overdose. Certainly slow heartbeat, bradycardia, difficulty breathing, muscle weakness, and seizures. Those are pretty serious, but if you notice the drooling, that could be a sign of overdose. Interesting, before giving this medicine, the physician normally assesses their swallowing because this patients may develop difficulty swallowing as the disease progresses, and the physician wants to know a baseline, what their swallowing capabilities were before treatment. And certainly never crush meds to give them, open them up, dump them in applesauce, something like that. These are very serious drugs. And to the left, I've always told you to watch these drug alert boxes on the left. On page 420, it has two listed here that you give twice a day with food to minimize GI upset. Rimonel and Exelon cause a lot of GI upset, so you need to give them twice a day with food. Teach patient care providers to use the bathroom, to help their patient to the bathroom every 2 hours. To avoid incontinence. We also involve the family and patient caregivers in the teaching of these medications and treatment of Alzheimer's. The family members of Alzheimer's are usually the caregivers, and very, very difficult time for them, and they need to understand what is going on with their family member, what meds they're on, what side effects to look for, what safety precautions to take. So you want to involve family members when you teach the patient. Aricept is given at bedtime. I'm looking here at what to teach patients about taking drugs for Alzheimer's. I've made a note to tell you that Aricept is given at bedtime, and the Rimonel and Exelon twice daily with food. You may need to know that. I'm not sure why I marked that in my book, but pay attention to that. Okay, moving on to Parkinson. As we talked about, Parkinson's progressive slow degenerative disease and of the nervous system. Many patients are coming down with Parkinson, especially age 50 or older. That's the major risk factors, your age, and then genetics and environmental factors. 2 abnormal genes have been identified in people with Parkinson's before age 40. And then environmental factors can lead to Parkinson's. And then there are drugs that can cause Parkinson's, and those are listed above. Again, I told you it's amazing how all these drugs, it's not really amazing, it's not surprising how all these drugs interact with one another. Compazine, Haldol, we talked about Haldol, or we will. Haldol wasn't necessarily given a lot when I nursed, but it was given very cautiously even then. And especially we know now not to give Haldol to the elderly, and it can cause a lot of serious side effects. I don't even know that you see Haldol given very much nowadays. Compazine, though, we've talked about. Reglan, all of those are for GI motility issues, and illicit drugs, of course, can cause it. We talked about the interruption of nerve impulses in both Alzheimer's and now in Parkinson's. And we need those neurotransmitters that trigger the next nerve cell to the nerve cell to send impulses. And in Parkinson's, these nerve cells degenerate, and thus the problems. Symptoms of Parkinson's disease, bradykinesia, that is the reduced movements when they start walking real slow, decreased arm swing when walking, difficulty rising from a chair, turning in bed, lack of facial expression. These are the motor symptoms. Their handwriting, can't really stand up still, stooped, shuffling gait, tremors. Those are some of the motor symptoms. Tremor. They also get a rhythmic tremor in the hand, and we call that pill rolling. They'll kind of do their hand like this, and we call that pill rolling. Very, very common sign of Parkinson's. The 4 major symptoms of Parkinson's: tremor at rest. 4 major symptoms: tremor at rest, rigidity, bradykinesia, and abnormal gait. The goal of treatment for Parkinson's are to minimize the disability, to reduce possible side effects of drugs, and help the patient maintain high quality of life. Excuse me. Types of drugs that we use. The common drugs are dopaminergic dopamine agonist. And as I said, the dopamine is what creates those neurotransmitters. So usually in Parkinson's, they have a lack of dopamine. And so we give Requip is one of them. They increase the amount of dopamine activity in the brain, thereby reducing the tremor and muscle rigidity and improving the movement. Carbidopa prevents levodopa from being converted to dopamine before it reaches the brain. So we have the dopamine agonist, commit inhibitors, Tasmar being one of them, and MAOB inhibitors and anticholinergic drugs. So you need to make sure you know with Cinnament, maybe a drug I asked you about. It's given twice daily. You need to avoid crowds when they're taking Cinnament. Requip is another dopamine agonist. Tasmar, you may be asked a question about Tasmar. Cogentin, may ask you a question about Cogentin. Dopamine agonist is Nupro. May ask you a question about Nupro. And Nupro is usually, while I'm talking about it, Nupro is usually given on a patch, like a nitro patch. And so you want to make sure you take off the old patch before you put on the new patch. Neutropenia is certainly an adverse effect also of these Parkinson drugs. Comet can cause a neuroleptic malignant syndrome or rhabdomyolysis. I think we've talked about that before. If not, it's a serious, potentially fatal effect involving the destruction or degeneration of skeletal muscles. So it's called rhabdomyolysis or neuroleptic malignant syndrome. The signs and symptoms of that are muscle aches, muscle weakness, and dark colored urine. So if your patient comes to you and says, why is my urine like really dark? Then you need to think of rhabdomyolysis anytime. But these meds, Comet inhibitors, and that one was Tasmar or Compton, can cause rhabdomyolysis. Always ask the patient before giving that about muscle aches and muscle weakness, that sort of thing, before starting it. And then if they come to you and say, you know, my joints are really hurting, my muscles are getting real stiff, you know, you need to ask about that. Certainly after giving these drugs, you're going to watch for hypotension, dizziness, nausea, all of these muscle aches, all of those things. Read what to do after giving Parkinson drugs. Signs and symptoms of adverse effects are listed there in 26.3. So the neuroleptic malignant syndrome, you need to know which med causes that. Neutropenia, you need to know which meds cause that. And the rhabdomyolysis, and know the signs and symptoms. And foods to avoid if taking MAO inhibitors. Let me see. Cogentin. Azlatec is one, and Eldepril. You need to be sure and watch these foods if they're taking MAO inhibitors. So aged cheese, avocados, bananas, etc. So there's a lot there to read as far as dissecting each one of your drugs, side effects, teaching instructions, etc. But I've talked to you about a lot of those already. Okay. Moving right along to chapter 27, psychiatric problems. So the key terms, anti-anxiety drugs, antidepressant drugs, antipsychotic drugs. So there's 3 different kind of categories. Benzodiazepines, what is depression, what is psychosis, what are SSRIs, and tricyclic antidepressants. Make sure you know those terms. So psychiatric disorders are a broad group of illnesses, just as you can see in the key terms. Mental illnesses, psychological illnesses, major depression, generalized anxiety, bipolar, schizophrenia, a lot of categories of meds. Major mental illnesses are the most common cause of disability in the United States. So psychiatric issues are the most common cause of disability in the United States. Certainly, you're going to always assess your patients for suicidal thoughts or actions. After giving meds, you're going to assess their blood pressure, dizziness, all of that. And you're going to teach the patients to report signs and symptoms. They must avoid alcohol because of drowsiness. So depression is an illness characterized by persistent feelings of sadness, despair, lack of energy, difficulty dealing with normal daily life. It involves the body, mood, and thoughts, and affects how a person eats and sleeps and how they feel about life itself. Women are twice as likely as men to experience depression, and men are less likely than women to seek treatment. So women will go seek treatment. Major depression is a disabling mental disorder marked by a persistent low mood, lack of pleasure in life, increased risk of suicide. Dysthymia is a chronic but less severe form of depression characterized by moods that are persistently low. These feelings are not disabling, but they can have periods of major depression. And you know the symptoms. I'm not going to go over that. Symptoms of mania, you know those. Bipolar, formerly called manic, is characterized by cycling moods from severe highs to severe lows. And the most common treatment for depression includes counseling, psychotherapy, and antidepressant drugs, but we certainly want to include counseling and psychotherapy. Depression treatment is individualized, taking into account the severity. Most patients are treated as outpatients. However, patients who express suicidal thoughts or suicidal ideation need to be hospitalized for treatment. The exact cause of depression is not known, but there are theories about neurotransmitter levels and a neuroendocrine function, psychological factors. Research suggests that depression may be caused by an imbalance of brain chemicals called the neurotransmitters, which we talked about. For example, serotonin, dopamine, norepinephrine. Communication between these neurons in the brain occurs by the movement of these chemicals across a gap called a synapse. Neurotransmitters are released one neuron at the presynaptic nerve terminal and then cross the synapse where they may be accepted by the next neuron. When the neurotransmitter levels decrease or become imbalanced, the neurons may be less able to communicate with each other. So these synapses are very important. These neurotransmitters have to get from one nerve cell to the other. And for some reason, there's a breakdown in those. And we're thinking that that's what's causing a lot of these mental disorders. So the drugs are called antidepressant drugs, and those are used for people with, of course, depression. And we want to see an improvement of symptoms. The two most common groups are selective serotonin uptake inhibitors, or SSRIs, and tricyclic antidepressants, or TCAs. SSRIs have fewer side effects and more commonly prescribed. It's important to know that it takes at least 8 weeks, 2 to 8 weeks, but we say 8 weeks for symptoms of depression to improve. So if your patient says, after a week, I'm not feeling any better, it's important for you to tell them, it takes 1 to 2 to 8 weeks for these symptoms to improve. And SSRIs work by increasing the amount of serotonin in the brain by inhibiting the reuptake. So TCAs inhibit the reuptake of neurotransmitters, norepinephrine, dopamine, and serotonin by the nerve cells. So that allows these neurotransmitters to go across the cells. But symptoms can improve, but do not, the effects of these drugs occur immediately. But the patient symptoms often do not respond for 2 to 8 weeks. So, page 436, SSRIs. Celexa, that's a common one. Prozac, we've all heard of Prozac. Paxil, Zoloft. Those are the very common SSRIs. TCAs, Elavil, and Impril, or TCAs. And then you have serotonin and norepinephrine reuptake inhibitors. Cymbalta, you hear about those on TV. Norepinephrine and dopamine reuptake inhibitors, Wellbutrin, and combined reuptake inhibitors and receptor blockers. A common one is Desrel. You need to read about side effects and adverse effects. TCAs such as Elavil may cause serious adverse cardiac effects, unstable ventricular dysrhythmias, which you all know about, and abnormal heart rate. So TCAs such as Elavil, Tofranil, those can cause big time cardiac dysrhythmias. Serotonin syndrome is a rare adverse effect that occurs when levels of serotonin are very high. The signs and symptoms of serotonin syndrome include anxiety, agitation, sweating, confusion, tremors, restlessness, lack of coordination, and rapid heart. You need to really watch for that. It's called serotonin syndrome, and that's when the serotonin gets really high in the body. Be sure to ask your patient about St. John's wort, as that can worsen depression and should not be taken with any of these antidepressant drugs. Prozac can certainly cause this serotonin syndrome, so we need to watch for that. And I told you about reminding the patient it takes 1 to 8 weeks before their symptoms will improve. Remind patients to take their antidepressants even if they're feeling better, which they're going to probably tend to not do. That's one of the problems. They think they're feeling better and they quit taking it. Caution the patients who are taking any MAOIs and transitioning to an SSRI, TCA, or other antidepressant because of the serotonin syndrome. Anxiety is a feeling of apprehension. So we have panic disorders, generalized anxiety disorders, phobic, obsessive compulsive, post-traumatic stress disorders. A lot of symptoms of anxiety in today's world. These symptoms are listed on 27.3. You're probably very familiar with a lot of them, but you need to read about that. Anti-anxiety drugs are used. Mild anxiety is a common experience and usually requires no drug treatment. Moderate to severe anxiety is a symptom of psychiatric disorders such as phobia, panic disorder, OCD, and PTSD. Causes and external factors: financial stress, side effects of meds, stress at work, stress from an illness, stress. Use of illicit drugs. Chronic and severe anxiety are usually treated with anti-anxiety drugs. And in the past, benzodiazepines were used very commonly. And now we're trying to not use as many benzodiazepines. The good thing about benzodiazepines is that they work very rapidly within 30 minutes. So if we're having a major issue, the physician may give a benzodiazepine now. Xanax, Klonopin, Librium, Valium, Ativan, Cirax, those are all benzodiazepines. But those are usually now reserved for severe anxiety attacks. Beta blockers, you've studied about before. Remember, beta blocker slows the workload of the heart, slows the heart, helps lower blood pressure, and so beta blockers are sometimes used now for anxiety. Analytics such as Buspar is used. Benzodiazepines, they can become very dependent. That's the reason they're used less often. Patients can become dependent on them. Anxiety drugs, common side effects: dizziness, drowsiness, fatigue, headache. And you should not stop taking a benzodiazepine rapidly. You need to follow the physician's orders. Avoid alcohol, same things we've been talking about before. Psychosis is a loss of contact with reality. Can be brief or long-term. Common symptom is delusions, which are false ideas about what is occurring or personal identity, or illusions, which is mistaken perceptions, or hallucinations, which is seeing or hearing things. Drugs for psychosis are antipsychotics and other drugs such as lithium. Major tranquilizers are most commonly prescribed for psychosis, and those are listed there: Abilify, Chlorozil, Seroquel, Risperidol. Those are all antipsychotic drugs. They all cause CNS side effects, And lithium causes a hand tremor and other issues. But severe life-threatening adverse effects can occur with antipsychotic, and one is tardive dyskinesia, and that's a disorder characterized by involuntary movements, usually with the mouth and lips, and so they smack kind of with their tongue, and that's called tardive dyskinesia, and that comes with lithium usually. Neuromalignant syndrome is rare but potentially life-threatening, involving the dysfunction of the autonomic nervous system, and that has to do with heart rate, blood pressure, digestion, and sweating. So if your patient starts showing these signs, you need to watch for neuroleptic syndrome. If the patient is taking Seroquel or Zyprexa, they need to avoid grapefruit. And pretty much I tell people nowadays they just need to avoid grapefruit. I had a physician tell me years ago that he had done research, and that was way back when, I may have already told you this, in the 80s. And I thought I'd never heard that before, but sure enough, it's come to light now. There are a lot of research about grapefruit and medication. So here they're telling us again for these antipsychotics to avoid grapefruit. And in the older population, most of the antipsychotic drugs, especially Thorazine, can cause a rapid fall in blood pressure. And so you need to watch for orthostatic hypotension in the elderly. Lithium can cause excessive urination and quickly lead to dehydration. Remember, dehydration is the #1 problem in the elderly who are taking a lot of medications for blood pressure. So that's it for these 3 chapters. And I have also, I'm sure you've seen the PowerPoint and the quizzes. So good luck. Thank you.